there actually are people listening in, as there usually are. Anyways, so welcome to our DMI's Thursday research conference. You probably have some questions as like, well, what does Bill have to do with blockchain, with social determinants of health? You will find out. I'm looking forward to giving this talk, to actually sharing with the department this activity. I've told some people about it. It's not a secret or anything, but you'll hear a little bit more. OHSU has been involved in this basically business incubator around 4 non-financial uses of blockchain, which I'm still trying to figure out what they are. But anyways, and John has helped me. So I will, I've been working with John Clouse, I'll introduce him in a moment, because OHSU is a partner in this incubator. And actually in John's first slide, he'll tell you a little bit more about it. But basically looking at some health applications. And the one company that kind of emerged to step forward, a company called Patientory, which you'll hear a little bit about, is interested in tying social determinants of health data to blockchain. So, so part of the purpose of doing this is to share this with you all. There's a secondary motive in that we actually submitted a presentation to the HIMSS conference in March that's been accepted. So we're presenting it there. So this is also gives us an opportunity to do a little bit of a dry run, see what we may need to add or subtract from our slides. And so being as verbose as you all are, you'll give us good ideas, positive and negative. Anyway, so before I start, let me introduce John Clouse, who works for Moda Health, which does have connections with OHSU, although really neither of us are kind of at the level of the sort of Moda OHSU connections. My main connection to OHSU, like most of you, is that they administer our health insurance. But John has nothing to do with that, so don't complain about those things about Moda. Anyways, but Moda is also a partner in the incubator, and you'll see kind of some of the ideas that we have. So John is a data scientist at Moda, and he has 2 master's degrees from University of Washington in information science and an MBA. And so I'm going to turn it over. So he's going to talk a little bit about the incubator. I will kind of set the stage around social determinants of health, and then he'll talk about blockchain, and then at the end we'll try to tie it together and share with you some of the things that we're hoping that might come out of this incubator. And there are some others who are hopefully connected to the web stream and are listening in. And as always, if anyone has any questions outside of OHSU, fire off a tweet and put hashtag DMICEConf, DMICECONF on it, and we'll follow the Twitter feed to try to answer your questions. So I will turn it over to John.
Thanks, Bill. So social determinants of health and blockchain aren't necessarily an obvious connection. Just to calibrate on the room, by show of hands, how many people were primarily interested in the social determinants of health component? Okay. And primarily interested in the blockchain component? Okay, so we're weighted on the social determinants of health side. That's good. To calibrate on blockchain, how many people have heard of cryptocurrency or Bitcoin? Okay, so solid. And then separate from the idea of cryptocurrency, has anyone done reading or looked into blockchain as an independent technology? Okay, solid. Well, I'm hoping that in addition to talking about the introducing blockchain, we can make the case for a practical real-world example, which is actually pretty tricky outside of the finance space. So the conversation that Bill and I have been part of joined up with the Oregon Enterprise Venture Block Studio, which was a local firm. RGA does some consulting and some startup processes for organizations, and they were interested in leveraging the potential of technology in Oregon, in Portland in particular, and trying to see if there's something about blockchain and the development expertise in state that we could harness to kind of build a sort of ecosystem around. And the state bought into their proposal and helped to bring together a consortium of companies to look at these non-financial uses for blockchain. So Umpqua Bank, OHSU, Moda, a number of other organizations came together with experts in the blockchain space. So that's where OHSU and Moda came in. There's a group called Patientory out of Atlanta that is in the population health space. So in between primary care and insurers, the idea of trying to help with population health and all of the challenges involved in that around integrating information and connecting social services, primary care, specialty, and the needs of an individual patient that really are not a core competency in some primary care practices. So Patientory came to this with a technology bend, with an interest in blockchain, and as we were talking across the participants' organ about the opportunities, the idea of addressing the needs for collecting information on social determinants of health that span organizations and healthcare boundaries rose to the top as one of the most practical implementations. So we spent a number of months going back and forth, putting together a case that led to drafting a paper that was the origin of the presentation for HIMSS and where we're at today. So from here, Bill talk about the social determinants of health and the context why these are important, and then we'll talk about blockchain and how those fit together.
Okay, so I actually have to admit I'm not the foremost expert on social determinants of health, and maybe there's others in the audience who I could just give this to and you can give my talk. But as part of this project, I've become more familiar with it, and of course I'm well aware that social determinants of health are probably more important to actually people's health, especially people who are impacted adversely by social determinants of health than what we do in the healthcare system. And so I think one of the driving questions for this project is, are there technologies that can help capture information about social determinants of health that can be used by the healthcare system or others to attempt to ameliorate some of those problems? So really, I'm going to talk about just some definitions for those of you who are less familiar, some of the challenges around social determinants of health, and then naturally there are some informatics aspects to it that are important. So it's been estimated that really only about 20% of impact on people's health actually comes from the healthcare system. I mean, we're in the middle of a big healthcare system here. That's what OHSU does. It provides healthcare. It trains healthcare professionals. But I probably don't need to convince anyone that there are many other factors in people's lives that impact their health. And this figure comes from the URL listed here that just lists some of the other factors that impact people's health. Such as behaviors, diet, smoking, exercise, things like that, social and economic factors, education, employment, income, family and social support, and the physical environment where people live. So people have challenges with housing, with nutrition, and things like that adversely impacts their health, and that only the healthcare system can only do so much for. Again, probably something that most of you know. I actually read yesterday that finally, after reversing a 5-year trend of life expectancy going down, it's ticked slightly back up in the U.S. But among developed countries, as you all probably know, life expectancy in the U.S. is among the lowest. And there's all sorts of reasons for that. Our healthcare system is certainly part of it, but there are many other factors. Income disparities, housing, transportation, and so forth. And there's this adage that, with apologies to the bioinformaticians in the room, where the genome is supposed to be the determinant of your health. It is, no question about it, but actually your zip code is a big determinant of your health, where you live. That indicates your likelihood of employment, of good housing, and so forth. So to achieve all that, all the great things we can do with understanding more about the genome, some of these problems need to be addressed as well. So the Kaiser Family Foundation has another model of social determinants of health. Most of you are probably familiar with this, but all of these different factors lead to health outcomes that people have. And sometimes in our society, the public health view and approach to health can be at odds with the medical approach. So this paper was it's a viewpoint that was published in JAMA several months ago. They noted that in Flint, Michigan, with the lead in the pipes, that was actually discovered by a clinician, by a physician who noticed high levels of lead in patients that were showing up at his clinic, and that led to investigation and ultimately discovering the pipes. So that's a great public health story, but that's in contrast with, and I actually see there's some EPC folks here, the U.S. Preventive Services Task Force guideline is equivocal about lead screening, and at a population level, there might be some equivocations about that, but there are also some reasons that it's really important to screen certain populations for lead. And so the public health approach is not necessarily at odds, but sometimes it just prioritizes things different, and we need both. And the public health approach is probably better at managing social determinants of health. One way to talk about it is a kind of upstream. So the public health system is upstream, where people are kind of starting to enter the stream towards health problems. And then we're in the healthcare system, we're down here at the end of it, downstream, when some of these problems treated upstream could have improved things. And the healthcare system doesn't do a particularly good job of identifying social determinants of health. Part of it is because clinicians are really busy, their patient loads are increasing, they have to spend more time entering data into their EHRs, as we know, and they don't always get the opportunity to address social determinants of health. In fact, this study published last year found that only 24% of hospitals and 16% of physician practices were screening for a wide range of social determinants of health. And fortunately, the rates were actually higher among hospitals and physicians who took care of patients who were more likely to have social determinants of health influencing their health. But still, many of these concerns don't get addressed because of financial incentives, busyness, and things like that in the healthcare setting. But there are opportunities, and this paper that was also published last year kind of provides a nice almost use case. And in fact, when John, after he gets done talking about blockchain and kind of tying these two things together, we'll actually talk about Meals on Wheels as a potential organization. There could be many others. So what this study is about, most of you are familiar with Meals on Wheels. They go out, they deliver meals to people who don't have the transportation or the finances to get meals on a regular basis. And for the most part, Meals on Wheels goes and delivers the meals. But in this one instance, they actually trained the Meals on Wheels staff as they went out to look for things related to social determinants of health. And they uncovered all kinds of problems, health problems, things that were impeding people from providing self-care, mobility, home. The rest of them are all listed here. And over a 12-month period, the drivers identified 429 alerts for 189 clients of Meals on Wheels. And we'll talk about, one of the challenges is how to get this data to the healthcare system and to others who need it. And there's a possible role for blockchain here. This is just a diagram from that paper. I won't go through it, but just kind of showing the decision path that the Meals on Wheels drivers used. Another study done from our colleagues in Indiana, in Indianapolis, of the famous Health Information Exchange, they looked at an intervention where they provided what they call wraparound services in primary care. So the primary care system wasn't necessarily able to provide these services, but there was a screening process to look for needs that people had to refer people to appropriate social services that could help with some of the problems that were identified. And they actually were able to show somewhat of a decrease in hospitalizations and emergency department visits. So providing these services provided value in terms of reducing hospitalizations and emergency department visits. There are some interesting challenges around social determinants of health from an informatics standpoint. So for those of us who think about various systems we're implementing or data that we're trying to collect to do things with, so to keep these things in mind. This is actually the first person to show me this slide was Shannon McWeeny, because from her standpoint, the interesting part of this slide, so this is from a report by McKinsey, the consulting firm, looking at the amount of data that we generate in our lifetimes. And it turns out that healthcare data, clinical data, is actually really a tiny piece when you think of all the other information related to health that gets generated about us on the order of a petabyte, so over 1,000 terabytes, as opposed to clinical care, a mere half a terabyte. And so, so from an informatics standpoint, it's important because there's a lot of data out there. How do we organize that data, standardize it? I'll talk about that in a moment. Maintain the veracity of it. How do we know who it belongs to, whether it's been tampered with, things like that. And another challenge related to informatics is that our healthcare system, because it's not well optimized for social determinants of health, also isn't well optimized to collect data about it. So, for example, can we code ICD-10 codes to at least get that part of social determinants of health into the patient record? People have looked at the different controlled terminologies, the ones that most of you are familiar with, LOINC, SNOMED, ICD, and identified gaps. And while we're making improvements in our ability to capture structured data around social determinants of health, there are still gaps in terms of what is covered. One effort is actually looking at, and in fact there's been these Z codes added to ICD-10 CM that can be used for the clinical system anyways to add codified data to do things like population level statistics and so forth out of clinical data. HL7, the standards organization, has a project called Gravity that is looking at building out the structured data around social determinants of health. And I assume over time this will get incorporated into FHIR, which is becoming the standard way that we maintain information, at least in the healthcare system. And another interesting paper, this actually comes from OHSU, which most of you are familiar with OHSU. In their build of EPIC, they have actually implemented tools that help capture data around social determinants of health. I don't know if some of our fellows who rotate at EPIC can tell us more about it, because I pretty much know just what I've read in the paper, plus I know Rachel Gold, who was the first author on it. And being able to capture, at least have the ability to capture social determinants of health information. And finally, I'll close with, something some of you probably saw last week. The American College of Physicians, which is the specialty society for internal medicine physicians, there's a number of us in the room who are members, actually came out with a major health policy, actually statement would be an understatement. They came out with, it's actually a supplement to their journal, Annals of Internal Medicine, a plan to improve the healthcare system, everything from financing to quality measurements. And there's actually two articles in this supplement, which is available open access. And of course, we get Annals of Internal Medicine anyways in our library, but they actually made it open access so anyone can get to it from anywhere. And two of the articles address social determinants of health, including the article by Karen DeSalvo, who previously was the director of the Office of the National Coordinator for Health IT, and now is the Chief Medical Officer of Google. So it's gotten attention that way. So I think this is my last slide, and I'm going to turn it over to John.
So social determinants of health, if you'd like generalize them as to who has a transportation need, is there a housing issue, is there food insecurity, is there ability to understand and follow a care plan? So if we say those are the social determinants of health, where are they recorded in our medical record? Who really knows the answers to those questions, and how timely and accurate is that data? There are three challenges for social determinants of health right now. First one is alignment. As Bill was saying, what's the taxonomy? How do we record them? CMS has one standard. Other national organizations are coming up with competing standards. That's just a process and an alignment issue. There's a technology challenge. How do we work on the interfacing? How do we bring that data into the right ecosystem, in particular the electronic medical record? Those two challenges are manageable. They're normal. They're pedestrian. The third challenge is trust. So that is the barrier. In the Meals on Wheels example we'll talk about later, there is somebody who has daily exposure to a patient and their social circumstances and the changes, and they have a relationship with that person. They are the best primary evidence. However, there's no trust for that. Who is that person? Would we let them into Epic and make a change in a medical record? And so that third challenge is really a serious barrier to being able to integrate social determinants of health into clinical information and be able to use that to do segmentation and risk stratification. So this is where the tie-in to blockchain, and it will hopefully explain what blockchain is and then why that trust issue is so paramount to the challenge of social determinants of health and integrating with healthcare, and how blockchain could possibly help address that. So I think the first challenge is to demystify blockchain. So I think if we said, if you wanted one takeaway from here, if someone asked you what is blockchain, the simple answer is blockchain is just a database. So if you take that away, that's all you need to remember about blockchain. However, it's unique. So typically, a database is at the center of an organization. It's at the center of a medical record. And because it contains such crucial information, it's usually hidden behind firewalls and layers of security and trust. So for you to get access to the database, you have to be part of an organization that trusts you. They give you a login so that they can authenticate you, and then they authorize you to do things. And that works because that organization has control over everything, and they can build a firewall around it. So that's the traditional database. And we said blockchain is also a database, but what's fundamentally different is it leverages technology so that it no longer has to rely on trust. In fact, everybody could have a copy of that database because the technology prohibits somebody from gaining access to something that isn't theirs, but allows them to enter transactions or information that's relevant to the intersection of a member and a provider care team. So this has been used in financial places. Blockchain is actually the solution to a problem that digital currency was facing. How do you manage a currency that's not regulated by a bank or a government? You can't trust some .com to say that we'll give you money and they'll manage a digital currency. So the idea of how to gain consensus, how to have a trusted database that nobody owned, was resolved in the creation of Bitcoin. So blockchain is a database. There are a couple of distinguishing factors that explain why it does not have to rely on trust and why it's so secure that instead of hiding it behind a firewall, you could put it out on the internet. So those three principles are decentralization, distribution, and immutability. So they're kind of jumbled together. We'll take them apart one at a time. In common language, decentralized and distributed can kind of be used interchangeably, but here we're going to make a distinct difference. So decentralized means that there's no one controlling organization. Credit cards work because VisaNet controls those transactions and interactions, and people enroll, and if VisaNet trusts them, then they transact through that trusted environment. In a decentralized environment, there may be many groups working together, so it could be OHSU, Moda, Meals on Wheels, Providence, a care provider, social workers, health coaches, but none of them are controlling the system. There's no one medical record that everybody's logging into that everybody trusts. We've decentralized that across multiple organizations. One of the ways that they protect against fraud or manipulation is to distribute the database. And so in this case, it is a physical distribution. Because it's so secure, everybody could have a copy. And the advantage to having multiple copies distributed across a region across the world is that it makes fraud very difficult to perpetrate. So in the case of social determinants of health, it's going to be more around access to the data and being able to make read and write changes to that database. In the space of cryptocurrency, it's about guaranteeing that no one has created a fraudulent version of those transactions that you're trying to populate. Yes?
Does the functioning of this system work because we can assume that there's no collusion between a significant portion of the users?
Yes. So so the question is around how do we know we can trust this? So the distribution means that multiple people have a copy. The challenge historically was how do you gain consensus? So if everyone has a copy, you want the majority to be determined to be right. So if a single party tried to create a fraudulent transaction, the majority would overwrite that and ignore the fraudulent piece. The challenge historically had been is that there was no mathematical or technological way to guarantee a true consensus, especially if somebody could fall off the network for a little while and then come back on and have to catch up. You could have multiple people claiming different versions of the truth or multiple truths over different times. So if you're familiar with Bitcoin and the idea of cryptocurrency mining, all the electricity that goes into mining is not producing new Bitcoins. It's not mining in a physical sense. It is literally proving that they've done some work. They've made it so hard. What they've done is they've made it hard to make an entry into that distributed database. And it's made more difficult the more people that are participating to make fraud impossible. And so it's difficult to do an honest transaction. It's then impossible to do a dishonest transaction. That was the original problem of proving consensus so that we could trust that distributed network. And that was originally associated with a lot of electricity usage. Hard means electricity. It took electricity to power the computing cycles, to solve a puzzle to guarantee that someone couldn't fraudulently enter transactions. Since Bitcoin was invented, there are now ways of providing consensus that don't depend on that, but that still allow multiple people to have a copy, but fraud not to be perpetrated. There's a nuts and bolts on that would be kind of fun to dive into, but you're on the right track. So distributing copies is a key to being able to trust and make sure that there's not fraud. So we have centralized, decentralized. There are a number of examples. So VisaNet, for example, is centralized. There's one controlling party, but they've distributed nodes across multiple locations. Real estate land title is in many cases centralized and non-distributed. It's often a paper book someplace. So there's a model for Bitcoin which is decentralized and distributed that was unique as of its time. So there are copies of that database all over the world, and there is no one controlling party that dictates how that works. So those two things alone aren't enough to guarantee transaction integrity. So the third piece is the ledger. So a ledger it could be a set of transactions like credits and debits. It could also be vitals and diagnostic codes and chart notes. So it's just anything you would put in a database. And in a blockchain, they take a bunch of transactions and they group them together, and they call that a block. So when that block is filled, they go on and create the next block. So that on its own would not provide enough security to guarantee someone hadn't gone back and changed a transaction, or that we know who made that transaction. So it goes one step further into an immutable ledger. And so it starts again with a set of transactions. And those transactions are signed mathematically. And that signature creates a unique fingerprint for those transactions. The fingerprint is over 64 digits long. You can't change a single period in those transactions without coming up with a completely different signature for that. So that first block is finished, signed, and its signature is the very first thing in the next block. And so it proceeds to add more transactions, come up with another signature, and now that signature starts our third block. So you can kind of see how this chain of blocks works together. You could not change a transaction upstream without affecting its signature. Its signature was written into the block that followed it. So everybody can easily check the integrity. Do these transactions produce the right fingerprint? That takes milliseconds to check, and they can check the entire chain. So that's the origin of the blockchain nomenclature. So it guarantees that multiple parties have a copy, no one owns it, and no one can change it fraudulently. So maybe if those were the components, it might help just a little bit to talk about how blockchain works. Blockchain is a network, and so as an individual, if I'm transacting in Bitcoin or I'm going to send social determinant data into the network, I log into my computer, I use my credentials to say I'm me on my account that I've set up on my own without an authority. And when I enter my data, so the vitals on a particular person, that information is encrypted and broadcast to the network. The network has a bunch of nodes that are listening to create those blocks. They gather up a set of transactions or health information entries, and they mint a block. They form a consensus on who owns the right version of that blockchain, that set of the database. And then that new block and the rest of the chain is published back out to the rest of the network. So think of it as a peer-to-peer database in that regard. So in our space, there are some interesting challenges. There's no way you can delete something in a blockchain. Everything is permanent, and everybody could have a copy of everything. So thinking about HIPAA and how we would work around that, in most of our day-to-day environments, when we encrypt something, we use one password to encrypt it and the same password to decrypt it. And that works for us, but if we have to send somebody a piece of encrypted information, we'd have to send them that password, and anyone who intercepted it along the way could get it. So that would be inherently insecure. Bitcoin would have been cracked a long time ago if that was what we were leveraging. So the blockchain uses a public key cryptography. It's a two-sided key. I have a secret, and I have a public key. And so I can sign something. You know that if you have my public key, you can guarantee I signed it. If I have your public key, I can guarantee you signed something. So when we talk about patient security, patient information, that privacy is protected by a two-way key. If we talk about the integrity of somebody outside of your healthcare system, outside of your medical record, making an entry, you can guarantee through the public key cryptography and the architecture of the blockchain that you know who made that entry. You can decide later if you believe their input or not. But there is no question as to the origin and the authenticity of that source. I don't think we'll drill into some of the compliance implications, but it's important when we're talking about social determinants of health, healthcare information, and the technology for storing that to look at the current environment. So HIPAA has portability as part of its prime directive, but most of its enforcement or most of its emphasis has been around privacy. So looking at HIPAA, GDPR from the EU, the California Privacy Protection Act, and the 21st Century Cures Act, evaluating a new technology and its ability to be compliant with some of those conflicting regulations is a key piece. And I think there's an excellent use case for blockchain being able to thread a needle through all of these. So we'll finish, I think, by putting a little more color around the Meals on Wheels example. So Meals on Wheels is fascinating. So as Bill said, it's a model where people are subscribing to a service. They may be facing food insecurity or the inability to prepare food for themselves. Meals on Wheels will prepare food at a central kitchen, and then it has volunteer drivers go out and deliver these. So the driver is given a list of names, and they walk to these same people usually every week, maybe different people every day, but they've formed patterns, and they cannot leave a meal if the person isn't there. If the person's there, they have face-to-face contact. They can see changes in their behavior, their eating habits, their disposition, their social determinants of health. And if they don't deliver a meal, someone from Meals on Wheels follows up on that. It's very interesting because small things like a customer being dropped from a list have a huge impact on their health outcome. How are they eating if Meals on Wheels is not providing the food that they needed? And sometimes it is not a core issue of food insecurity or something else. It's that delivery got canceled because the steps are slippery and the drivers can't come. And so those things would never show up in an annual wellness visit. And a primary care provider that's seeing them 1.6 times a year doesn't have the frequency and the depth of information. So these volunteers have fabulous insights into each of those social determinants. But we don't have a mechanism that would allow them to go into a medical record and make an update, because we don't trust all those unknown entities. And there's no mechanism to delegate trust to social service workers across all sorts of different areas. So the idea around leveraging blockchain to establish the veracity of an identity, to maintain a set of tightly controlled and secure transactions that integrate social determinants and healthcare and that are available across organizational boundaries. Right now, if Moda went out and gave Meals on Wheels an interface to our systems, we might know something. But then OHSU would have to create another system to go integrate with Meals on Wheels, and Providence and Legacy and Kaiser, and it's an impossibility. Meals on Wheels can't build and interfaces to proprietary systems. So the premise that blockchain is a technology that does not rely on trust, that could bridge a gap in social determinants of health and health outcomes is the premise that we came up with out of the Blockchain Venture Studio, and that we're trying to see where the conversation leads next.
So at this point, we will open it up to questions, comments. And Lynn has a microphone. There's a microphone up here. Is this going to solve all the world's problems, or maybe not? Michelle?
What do you do about patient identifiers? How do you know that you can match them up?
Yeah, so patient identifiers, today, if we got a list of patients from OHSU and we looked at our registry and then we looked at a hospital's registry, we have to do matching today. So at some point, there's a certain amount of patient information that's required to match an identity. And once we've done that match, we now know the Moda identifier and the OHSU identifier. And so we could look for that going forward. The same thing would happen if we extend this to social services. They'll have name, address, date of birth, gender, and that's typically enough with a zip code to get a match. And so that's kind of a standard information technology challenge of doing an initial match and then maintaining a lookup table for identifiers from each system. The blockchain would record those particulars and the organization that they're under, and if that organization had an identifier, that would be inside of the blockchain record.
Or we could do what most other advanced countries do and have a national identifier, but that would be too easy and not politically feasible. But in fact, the counter-argument to the national identifier is that there are entities, especially technology companies, that are really good actually at matching people. So it likely would work an overwhelming majority of times to use the kind of matching that HIEs and stuff do now.
Thanks for your talk. I was curious to know, so let's say I was receiving Meals on Wheels, and I've actually done Meals on Wheels before. So say I was receiving it, and my information was recorded in this health blockchain.
Yes.
I'm curious to know, so I would have to give basically Moda or whoever my health insurance was access to the key for you to
Yes.
have a collective, to be able to aggregate any information across me and perhaps other people who were either receiving Meals on Wheels or other mechanisms where social workers or other personnel were recording outcomes. What would be my incentive for giving my health insurance company that information?
Yeah, that's something we deal with outside of healthcare. When we agree to terms and conditions on a free service, we're kind of trading our access to our information for that service. When we sign up for a program, it has a certain number of benefits, and hopefully they're being very explicit about it. But that acceptance of that use of your information it can be established up front. And so you can opt in, you can opt out. For those that opt in, we could get that information. And what you'll see with things like the GDPR, General Data Privacy Regulation, I can't remember. The idea, though, is that you can opt out at any time. You have the right to be forgotten. And so using that information on the blockchain to record the current status of what you've opted in for. And
Transparency.
yeah, there's transparency. It's also upfront getting acceptance of those terms as part of membership in certain plans.
Thank you very much for the talk. This is really interesting to me. I have two questions specifically to one, the data that so traditionally blockchain has been used for financial transactions.
Yeah.
There was a very, standardized kind of data.
Yeah.
Healthcare is you have multiple different pieces of information with various length and complexity. How do you incorporate that into the very structured way the blockchain is created? And the second question is, is there any plan to do anything with the contract-based blockchains that like Ethereum and things like that? Where has it been come up with?
Yeah, actually those two questions do fit quite well together. So even on a blockchain like Bitcoin, traditionally it's being used to store transactions, debits and credits. But there's also an unstructured data field. So people have stored images, they've stored other data in a blockchain transaction. So there's no inherent limit or structure because it's on a blockchain. It just happens to be expensive on something like Bitcoin to record something other than a transaction. Another blockchain that's also a cryptocurrency is Ethereum. Ethereum took the starting point, which is transactions, and then it also added smart contracts, which are basically programs that can say they can run automatically. If they see something happen, if they see an input or something change, they can execute code. And so some of this could live in a set of transactions. Some of this could leverage a smart transaction. I think in the case of social determinants of health, we're really looking at this as a database that could be shared across users who don't have formal trust. So we're not looking to leverage some of the smart contract capabilities of like an Ethereum, but all those blockchains have the ability to store an arbitrary data structure. Ethereum is probably the most likely launch point, though, for something like this.
Thanks for the talk. It was really good. When you said all the users would have a copy of the database, I mean that's kind of the idea. How does it work in this technology that certain users don't have access to kind of all the information, and they would have access to only what is relevant? How is it possible in this technology?
Yeah.
And my second question was, in this model, who is going to pay for this?
Oh, okay. Those are unrelated questions.
Yeah,
Let me tackle those first. So I should have been more clear. Everyone could have a copy of this data. So a node, and when we looked at that mesh distributed picture, a node has a copy of the database. And so if we were doing a lot of work on that blockchain, we may have our own node so that we have a current copy. If we didn't have our own node, we could always address any other node in the network. So it's a peer-to-peer database. You don't have to have your own copy. Your interface could go to talk to somebody else's. You have the right to maintain a copy. And that's an advantage in the space of cryptocurrency because it prevents fraud. Here, it's just a matter of accessing the data in a more timely manner. So if everyone could have a copy of that database, whether they choose to or not, it's that public key cryptography and leveraging also a symmetrical key so that we know that the person who created that data or the member that that data represents is protected by a public key. And that way, even though everybody has that transaction, they can't read it. They would need the opposite key to reverse that encryption. So everyone has a copy of random numbers, random looking numbers, that they couldn't do anything with unless they have the right keys.
Thank you.
So the second part of your question is who pays for it? I think that's the challenge, is that this is in a space where it's predominantly disadvantaged populations, perhaps Medicaid or some parts of the country where there's an outsized impact by social determinants of health. So, is there a Medicaid program that's funding this? Is there some sort of capitated care model that is buying into this? That's a challenge. There is no incentive to go build this infrastructure. So there's a lot of talk of social determinants in healthcare. There's a lot of individual organizations looking to see how they could engage, but there's no funding source right now.
In some sense, that kind of mirrors the question about health information exchange, HIE. There really still isn't a business model to give an OHSU an incentive to send its data to Kaiser. I mean, I suppose now we have Care Everywhere, which is kind of part of Epic, but for patients who come from different places and things like that, there aren't financial incentives to send the data. I mean, unless you sort of take a kind of global perspective, like, oh, well, if someone pays to get that data to this place, then in the healthcare system, they might not need to reorder tests, or they could, be more efficient in how they make diagnoses and treatments. So, Lily.
Yeah, so I have a question about how this information would be used. It seems like it's intended to be used at the point of care, like by a primary care provider. So what would happen if, like the example you gave was, if Meals on Wheels reported we weren't able to bring this person a meal because it was too slippery out. Like, I have a hard time picturing. If I, for example, called a provider and said that my patient didn't get lunch today, they would say, "That's nice. Why are you telling me this?" So I guess what would be done with this information? What's the intention?
Yeah, so if you talk about population health, there's a whole spectrum of care. The provider might be the anchor, and they might be seeing that person 1 or 2 times a year, and they might be looking systematically, what does that patient need? If they are having challenges with disease management, chronic conditions, or social determinants of health, ideally, their provider network, their insurer is trying to get them into a population health program, a health coaching program, or maybe a disease management program. So those parts of the care continuum are designed for more hands-on day-to-day or week-to-week interaction. And so ideally, what we'd find is a change in their social determinants of health. We're using that information to segment a population, and see what kinds of needs there might be, and then to risk stratify. So build a model identifying highest risks so we know we're engaging with the right people first. So as those social determinants of health would be used to identify the right people for the right intervention, and then it's through a care coordinator or a health coach that we'd likely see that interaction take place.
You know, I would just add, I mean, I sort of talked about the kind of upstream versus downstream. It's probably not efficient to send the information to a primary care physician that so-and-so missed their lunch yesterday. But, there could be, population health. There could even be sort of population-level clinical decision support. Oh, Mr. Jones has missed, 3 meals this week. We should do something about it. And actually, especially like in a capitated healthcare plan where, you have some incentive to, keep people healthy, or at least to keep them from getting worse. So knowing that kind of information, it's probably best not to go to the physician, but there may be others in the kind of social services network that could benefit from that information and act on it.
That's a good point. In the example of someone being diagnosed with diabetes and then a prescription for insulin that's expensive, where that person lives, their economic situation, their housing security, their food insecurity, at some point the physician should know that if they're getting a prescription for expensive medication, they may be choosing between food or medication. Mm-hmm. And so at that point, can the physician enroll them in a program, find a drug rebate, or make sure that they're getting the lowest cost medication for that service? And today, that's not in the medical record. And so when we look at disease management, population health, if you look clinically, all of these patients might look the same with that disease. But when you layer on social determinants of health, there's a huge disparity between those who have someone else living with them, the needs, and to really understand why they have to take this medication the exact same time every day versus those who don't.
I agree. But it seems like typically, in terms of funding too, it seems like typically what is done is that information is geocoded into the person's record based on which census tract they live in, and then that can be linked to census data. For example, that's what OHSU did with their advanced CDRN databases. They just had it geocoded, so all of their patient information links to information from that person's census tract, which seems like an easier and cheaper way to do it. So full disclosure, my research area is in geocoding and use of location based information and social determinants of health. So I guess what I'm saying is it's possible that my belief into how you could solve the same problem is a little bit self-serving. But what would be the advantage of doing it the blockchain way instead of the more typical geocoding way?
So I worked at block group and census tract level in terms of trying to look at the predictive value of models built on census tract information. And if we're trying to identify like the top 1 or top 5% proactively through models, what we're finding is that a census tract is still too broad to be able to identify and stratify patients. So getting social determinants on an individual basis to create a model that has a higher predictive value is the next step. I think census tract allows us to understand populations, and that's very useful. If we're looking at individual interventions, then like recording this primary data or acquiring it through third party is essential.
Great. So we have one and then one. Okay. That's probably be it.
Thanks. So to me, when I hear trust as a major challenge for using social determinants of health, to me that it would go beyond sort of data privacy and data security to some of the things that maybe Lily's starting to reference is what is done with that data. And I think that it seems to me we're still working out like ethical structures for that. And that might be way out of the scope of blockchain, but in what ways could blockchain help support that, for example, giving different levels of privacy or the ability to retract information or correct it or contest it, things like that?
Yeah, one of the other organizations that RGA and the Oregon Enterprise Blockchain Venture Studio was working with was an organization that was literally tracking opt-in, opt-out, all sorts of programs online. So they're creating a master registry. What have you opted into, what have you opted out of, and what dates and what's effective. So blockchain is a permanent record. You can't change it. So in this case, if someone opts in and we shared some piece of information, they opt out later, and then there's a concern, why did you share this? The nice thing about the immutable ledger is that we can say, on this date, there's absolutely 100% sort of, we know that we were doing the right thing then, it changed later. So blockchain kind of gives us a chain of custody for any changes in what we have authorization to do. It allows us to monitor that on multiple levels. So you can opt into one program, you can always opt out of a different one, and all these privacy rules are very, very clear on the patient always has the option to opt out, and we have to follow that.
Insurance company, right, covers fluoride supplements. So I feel like, yeah, it's a difficult scenario because the actual choice component of the model is really there for healthcare. There isn't really a choice.
I think there are different levels of opting in. So if you want to subscribe to a plan, and the organization has decided that there's certain information that has to be collected to administer that plan. If you want in, you have to buy off on that piece. When we do something like social determinants of health, that is a separate component. So people can opt in of a health coaching plan. If they opt in, if they want health coaching, we would need extra information, and so we have to allow them to see what we're collecting, and we have to explicitly get their permission to opt in and when they did it. But we compare them together, and a lot of organizations have been doing bulk registration. So they hadn't been collecting this before. They'll say, if you're in this program, we need you to sign this to maintain membership. So I think, especially with GDPR and some of these other compliance pieces, we're going to see, like when you go to your account, before it's your address and some other things about you, I think you're going to start to see your terms and conditions and your history of what your information sharing compliance.
Right. Back there.
Hey, I have a question and a comment. Can you hear me okay on this?
Yeah.
First of all, I work with OHSU. I'm one of the co-authors on the study you put up earlier about, and we are doing screening that is integrated into the EHR. So there are screening tools so people can ask at the point of care about the social needs that patients might have. So my one question is, what we're really struggling with is at the point of care, you find out someone has a need. What do you do? And so we've been working with creating these social service, or collaborating with places that are creating these social service resource locators, so we know where there's resources, but really wanting to figure out ways to communicate with those resources, and like from the point of care out, and maybe there could be bi-directional communication, and there's all these barriers. And could blockchain be something that works that way?
That was part of the kind of our original conversations. Was one blockchain was focusing on the patient, and another related blockchain was focusing on services. Okay. And so then we could see interactions between those patients and those services. Or so there's things like 211, where you could type in an address and it would tell you, here are all the social services in your area if they were working together. But there are all these individually maintained repositories. Different provider groups are going to maintain a list of social service providers, same with population health at Moda and other organizations. So the idea of, this goes back to, it'd be easy if the state just said, here, we're going to create a master registry of social services, or we're going to create a master health information exchange for social determinants of health. So in the absence of those two pieces, we're looking at how do you do that without trust, and blockchain is not the simplest solution. Right. If we could get legislative agreement on the need and the format for these systems, the state-run database would solve the problem you're talking about. In the absence of that, blockchain also could provide a way of going back and forth with the services, and they could add themselves, and then the provider could say, okay, based on who they are, I found a match, and I can decide if I want to enroll or not.
Gotcha. And
So-
one other quick thing I just wanted to
sure.
say is we have geocoded the data at OHSU, and we've done some looking, though, of people's self-reported needs and the geocoded census tract information, and it doesn't always match up. So I think that although, like you were saying, like the census tract information is useful, like there's still some relevance to really asking individual patients and looking at other kinds of data, I think, as well.
So we'll do before one last question for Jenna. Actually, a question came in over the Twitter feed, so I always want to make sure we incorporated that, and it came from someone who many of you know, Deb Woodcock, presumably out there listening. She actually phrased it as a sentence, but I'll turn it into a question. Because blockchain does not depend on trust, is it a potential solution for sharing social determinants health information among electronic health record systems? Which I think it is. I mean, that's part of the advantage to this, that if people had the proper authentication, then someone's SDOH information that's sitting off of blockchain could be accessed, either potentially incorporated or queried if your system didn't want to incorporate it. So,
If I can pivot
Yeah,
off of that.
yeah.
So it could be incorporated, but inherent, if we have a medical record, and maybe we could use Epic as an example, Care Everywhere, Care Anywhere create links. Those links are based on trust. All those organizations trust Epic and its management of those interchanges. So we don't need blockchain. That is a trusted, in a sense, it's a centralized database. Even though it's distributed across different health plans, that connection is done through Epic, and there's trust there. So I want to make sure, there's a principle called Occam's razor, and it's to use the simplest solution possible for a given problem. So in that example, we could add in information off the blockchain to that ecosystem, but we wouldn't have to use blockchain. If everyone's on a medical record that has a common trust, then that is the simplest solution. So as OCHIN and others start to add Z codes or the prepare tool or find that alignment, then the technology is there. So they trust each other. The challenge with trust then goes back to who really knows the primary evidence. And if it's a volunteer at Meals on Wheels, how will that get into the system? And there is no trust. And that's the unique challenge here, is that the person who really knows isn't trusted by the people who need it.
So if we just had Epic keeping all of our information, we could trust Judy Faulkner. No. Anyways, Jen, last question because we're a little bit past time.
If we're over time, I can ask it in person. But great talk, and they're two very interesting areas, and you talk a lot about trust, and blockchain is a great means of securing data, and you talked about trusting the person on the Meals on Wheels end, but I think there's a lot of lack of trust on the other end too, and patients trusting Moda, right, and the insurance company. And Dr. Hersh gave a great example of, we have these data that an intervention comes out, and the people with the social determinants of health lower their cost on the system, their medical costs. And the converse, or the unstated underlying assumption there, is that people with high social determinants of health needs are very expensive, and they have high medical costs. So now you have a system where the people who have the least means and the highest costs are getting flagged and identified, and the security of the data is there, but how do we trust Moda? What's being done to trust how those data are being used, and how are those data being used, and why should that part be trusted?
That's a good question, and probably a very nuanced one. So there are regulations in terms of what you can do with information and how you're aggregating risk and coming up with what's the right price for a particular product based on history. So there are all sorts of examples where one extreme case can make a very challenging situation, but there's legislation that you cannot single them out. You can't do carve-outs in that regard. In terms of care, especially when we're talking about chronic conditions, so something like an MS or diabetes or congestive heart failure with obstructive pulmonary disease, those people need care. They're expensive to the system, and I look at cost as a sign that something's gone wrong. So not only is cost something that the system is trying to manage, it's also an indication that patient's not getting the best care. Going to the emergency department is 10 times more expensive than going to primary care. So part of this involves people following the intent of what they've asked for permission to use that information for, and demonstrating that if we do have this information, we can find the right intervention for the right people, and their outcome is better and their cost is lower. And it doesn't guarantee people won't exploit that, but that is the only way forward to help those people. We can't help them if we can't identify them.
Yeah, I mean, we just, that's where laws and regulations come in. So laws, just like there's laws now about covering pre-existing conditions and things like that. And so those obviously need to be in place because there is actually a societal benefit for reducing someone's downstream healthcare costs. Even though maybe the healthcare organization, or the insurance company, whatever, may have incentives that are not really aligned with the patient and society at that end. But if you have laws and regulations and can try to catch some of these things upstream to do something about it, then presumably that will provide those protections. So anyways, I apologize that we've gone a little over, but this is great for us to hear your input. Thanks a lot.